All of my friends are. Oh, good. Because he died, he's going to be. So I took a notebook.
I want that box. Yeah.
I got back around 9:40. So I went by the bar. I'm sorry, I should have went. I thought you were like here. Well, no, I can. You must be your tank. Actually, what?
All right, hello everybody. We are going to get going here with the Leslie Blumgart historical lecture. I invited my friend Liz Pomfret to give this talk because she's an outstanding surgeon and chief of transplants at Colorado School of Medicine. So Dr. Jarnigan here is going to give a little introduction so we'll get going. Thank you.
Thank you, Magella. And congratulations on your presidency and congratulations on a really fabulous meeting. So several years ago, the AHBBA, in its infinite wisdom, established the Leslie H. Blumgart Lectureship to honor the many accomplishments, contributions, and the legacy of Les, the professor. And over the years, we've had several distinguished speakers give this address. And as most of you know, Dr. Blumgart passed away in September, just a few months shy of his 92nd birthday after a very long, distinguished career and a very colorful life. So as many of you know, I'm just going to give a few remarks about his life and legacy before Dr. Pomfret's lecture. But Dr. Blumgart initially qualified as a dentist in South Africa and worked there actually for many years before he uprooted his family and moved to Sheffield in England, where he took up the study of medicine while also establishing a dental practice. In 1962, he qualified with a medical degree at the University of Sheffield. He was, by all accounts, a distinguished student, particularly proud of the medals he earned in medicine and surgery, also pharmacology and anesthetics. I'm not sure what he thought about getting the best prize in the study of mental diseases, but as anyone who knew him knew, he was a very good judge of character. I'm sure that that somehow contributed to that award. To put his life in some perspective, other newsworthy stories in 1962, US and Russia stood at the brink of nuclear war during the Cuban Missile Crisis. And the Nobel Prize was awarded for the discovery of the double helix. So his life really spanned quite a broad, a wide breadth of history, both human history and medical history. In 1962, he was a house surgeon under legendary Professor Sir Kay, the Royal Sheffield, and he spent several more years there before he left to become a senior registrar, again at the University of Sheffield. In 1966, he qualified as a fellow of the Royal College of Surgeons. And it's interesting that, you know, although he was now a fully established surgeon in his own right, dentistry was always close at hand. This is a view of his one of his appendectomies caused by a swallowed tooth as the appendiculus. If we look at Dr. Blumgart by the numbers, and you know we judge everyone by numbers, college fellowships 5, 14 journal editorial boards, 30 visiting professorships, 32 major honors and awards, 32 years as a department or section head, 33 society memberships, 40 years in the practice of surgery, almost 500 peer-reviewed publications in HPV and pancreas alone, nearly 800 total publications, and over 2,000 liver resections. When we think of the professor, we think of the term mentor. And this is a term that people use without even thinking about it. It's overused, certainly. But the term actually comes from Greek mythology. And many of you probably know that mentor was actually a character in the Odyssey. And he was charged with raising Odysseus's son when he left to fight the Trojan War. So a mentor is not just a teacher, but one who imparts wisdom like a father. And that's what Dr. Blumgart was to many of us. And like the French and Italian, who didn't invent food and wine, but they made it an art, so too the professor raised the level of our specialty almost to an art form. When he was in his formative years, this publication by James Foster came out, and it just highlighted just how dismal we practice liver surgery. I'm sure the people at the ACS, if they were to look at the quality of surgery at the time, would have shut all of these places down. 25% operative mortality, you've got to be kidding. Terrible, terrible results. 20% of patients died in the operating room because of overwhelming exsanguinating hemorrhage and other horrible things happening. Dr. Blumgart, and not just him, but many of his contemporaries, elevated our field to where it is now practiced very safely. Since he came to Memorial 1992, he performed nearly 2,500 liver resections, 60% major hepatectomies. Fewer than 50% of the patients during this time were transfused, and operative mortality 2.5%, less than 1% since the year 2000. So he was a great surgeon, a great friend. His operating rooms were always crowded with visitors looking to see, just how he did things, and he did them very well. And when we think about, where he trained, where he worked over the years, the people he trained and where they worked and where they went, and the college fellowships, the visiting professorships, all the places he's been throughout the world, his reach was truly global. So we bid him farewell. We can't possibly thank him enough. And Prof, your legacy is great and will go on. Thank you very much.
Thank you, Bill. Great memories of the very limited time I had with Dr. Blumgart, but that was outstanding. So it's my pleasure to announce and talk a little bit about Dr. Liz Pomfret. She is, as I mentioned, she's Chief of Transplant at the University of Colorado. She is an established multi-organ transplant surgeon with additional training in living donor liver transplantation. She has an outstanding living donor program. She's an international leader within the field of transplantation. She has served as the executive director or the executive editor of the Journal of Transplantation, which is the most highly cited journal in the field. She has served as the president of the International Liver Transplant Society, ILTS, from 2014 to 15, and she's also the president-elect of the American Society of Transplant Surgeons. She is on multiple boards, and she's internationally and nationally known, of course, for her expertise. So I'm delighted to introduce you, Liz.
Well, thank you, Magella, and thank you to the HPBA organizers of this meeting for inviting me. This is a tremendous honor, especially this year. I'm very, very honored to be giving this lecture, and I know what a special person Dr. Blumgart was to everyone in this society. So, as I said, I'm especially honored to give this lecture this year. And what I'd like to talk about is living donor liver transplantation in the setting of liver cancer. the fusion of hepatobiliary surgery and transplant surgery. And I know one of the things that you're talking about at this meeting today is what's the ideal training for an HPV surgeon? And I would say it's to have as much in your armamentarium as possible, and that would include training with transplant surgeons. So I hope this is of use to everybody here. I have no financial disclosures. When we talk about dismal outcomes, I don't think anything could be more dismal than Tom Starzl's original series. And in one of his early papers from 1976, reporting on the surgical approaches to primary and metastatic liver neoplasms, he said, liver transplantation would rarely, if ever, be indicated for metastases of the liver. Now, why did he say that? Was that based on opinion or data? Well, at the University of Colorado, we're lucky to have his actual original operative logs. And this is his original operative log from 1963 to 1978. And what you can see is the vast majority of the transplant cases were either biliary atresia or cancer. And they were either hepatocellular carcinoma or cholangiocarcinoma. And I know it's difficult to see, but the survival was pretty dismal. Out of the first 151 cases, the operative mortality for 30 days was 27%. 1 year survival rate was actually less than 10%. It was 9.9%. Retransplant rates, 13.3%. His longest survivor was almost 6 years, but that was an 11-year-old with Wilson's disease. His longest adult survivor was almost 2 years, and that was a 28-year-old with alcoholic liver disease. Essentially, no patient with hepatocellular carcinoma or cholangiocarcinoma had a survival that extended beyond a year. They were all dead within a year. It was one of the reasons why he was essentially run out of the University of Colorado. So a reasonable conclusion, and a conclusion that the people at Colorado came to, is that liver transplantation might certainly be considered unethical or even crazy. But I would submit that what seems extreme today may well become ordinary therapeutic tools tomorrow. So March 1st, believe it or not, was the 60-year anniversary of the very first liver transplant done in the United States. And over this 60-year period of time, transplant surgery has been built on the foundation of excellence in hepatobiliary surgery and vascular surgery. That's where it all started. In 1963, as I said, the first liver transplant was done at the University of Colorado. In 1989, the very first living donor liver transplant was done. It was done unsuccessfully in Brazil, but the first successful series was reported by Dr. Christoph Brolsch at the University of Chicago in 1989. In 1993 was the first report of adult-to-adult living donor liver transplant in Japan. And in 1997 was the first adult-to-adult living donor transplant done in the United States, and that was done at the University of Colorado. Today, we're looking at the role of transplant oncology, and you've heard a number of different lectures being defined in transplantation and expanding the use of living donors to try to meet that need. But the timeless constant here is always balancing donor safety with recipient outcome. So here are two innovators who really, I think, laid the groundwork for living donor liver transplantation. And they were both hepatobiliary and transplant surgeons. Dr. Rudy Pickelmeyer, who unfortunately met an untimely death at the World Surgical Congress, where he drowned swimming in the morning in Acapulco. He was a mentor of one of my mentors, Christoph Brolsch. He was in Hanover, and he's credited with coming up with reduced size grafts. So taking an adult graft, paring it down on the back table, and then being able to transplant a child with that cadaveric graft. Henri Bismuth, who has trained many of the HPV surgeons who are in this society and transplant surgeons, is credited with coming up with split liver transplantation. So that's what I'm saying. It's the HPV and vascular surgeons really who laid the groundwork for transplant surgery. As Plato said, necessity is literally the mother of invention. So the scarcity of cadaveric organs is what led to what was considered to be a completely radical, by some, a completely unethical decision to go and use a healthy person as a liver donor. And Chris Brelsch, as I said, was the first person who published the first series. And this is the very first pair that was done in the United States. You could see the mom sitting with her daughter in the chair. She donated to her toddler daughter at the time. This is that young girl graduating and inviting Christoph Brelsch to her high school graduation. She went on to get married. She has since had 2 children. So you can see that obviously it was a great success. But I can tell you, when Christoph was planning on doing this and reported this at the Drake Hotel at one of the very early ASTS meetings, Tom Starzl stood up and told Christoph that this was the most unethical thing he had ever heard, and actually went further to suggest that maybe it was his German heritage that pushed him to think of doing such a thing. So, transplant oncology. You've heard a couple of lectures about it. This is how far we've come in transplantation. We heard that Mazzaferro was the one who really pulled us into this by saying that, okay, if you don't take all comers with cancer, but you select them carefully, you can have great outcomes. And so that was where the Mazzaferro criteria came up. And we know that if you select HCCs carefully, you can have outcomes just as good with a hepatocellular carcinoma as you can have with any other type of disease that you're transplanting for. You can also see that it was the Mayo Clinic that came up with looking at perihilar cholangiocarcinomas. And again, well selected with well thought out protocols. Again, excellent outcomes. Mazzaferro came up with good criteria to look at neuroendocrine tumors and using transplantation. The Oslo group introduced the concept of looking at transplantation with well-selected patients with colorectal Nets. Gonzalo, who spoke yesterday, I always screw up his name, so I'm just going to call him Gonzalo. He knows who he is. He's fabulous. He is the one who presented yesterday about the intrahepatic cholangiocarcinomas and using living donors, and has shown excellent results from their group in Toronto. Kerry Lunsford from Memphis looked at using transplants for people with large intrahepatic cholangiocarcinomas. And there's more recent data from that group that was published in AJT in 2021. And then Roberto Hernandez published the living donor liver transplant, small series, but living donor liver transplants for colorectal Nets. So we've come a long way. And today I'm really going to focus just on living donor liver transplants. We've had a load of discussions in the transplant world about what's the minimal acceptable survival at 5 years that we should be looking at for using a deceased donor for cancer. And we don't have a great idea of what that should be, but we always seem to come up with it should be somewhere around 50 to 60% survival at 5 years. Other people feel the bar should be higher for a deceased donor because the scarcity of the organs are just so extreme that maybe it should be more like 50% for 10 years. Hard to say. But certainly we know that living donor is a different animal. And this is a slide that was provided by Nico. And I think it's a really beautiful slide, because what it shows you is that if you're talking about deceased donor, you have to take all these different things into consideration: the positive gain for the transplant community, positive gain for the patient, the negative gain for the patient, the negative gain for the transplant community. And so you have to ration all of these things when you're talking about a scarce quantity like a deceased donor organ. So you can't be doing things like, totally out of bounds HCC, poorly selected cholangiocarcinomas or colorectal metastases, because that's a waste of an organ. Or it might be considered, completely, arbitrary to be doing things that are kind of marginal. But when you have a living donor and that person understands the risks of what they're doing, and they accept that risk because they're willing to do it for their daughter or their husband, then that's a different story than looking at the scarcity of an organ for a deceased donor. So we have to look at it in a different way. It's not the same thing as deceased donor, where you have to balance utility and justice and all of those sorts of things. But we can't throw ethics totally out the window either with living donation. So what are the current results with looking at living donation and cancer? Well, we've had an improvement, certainly, in how many cancers we're transplanting, and that's because we've been able to successfully cure hepatitis C. Right now, hepatocellular carcinoma is the primary diagnosis in almost 11% of the people sitting on the waiting list. Although you can see in the upper graph, the line that's doing the big plummet is hepatitis C, and that's since the advent of having direct antivirals. So we've been able to cure hepatitis C. That's made a big improvement in terms of decreasing the number of patients who are developing hepatocellular carcinoma, but there's still a large number of patients that we're transplanting who had hepatitis C, who subsequently have developed hepatocellular carcinoma. But the rate of people that have hepatocellular carcinoma that we're transplanting is certainly much lower than in the past. The outcomes are actually excellent. So whether you're talking about deceased donor or living donor, I'm going to show you deceased donor, graft, and patient survival. You can see that the outcomes, whether you have hepatocellular carcinoma or not, are essentially equivalent when you look at 5-year outcomes. And living donation, not quite as good. Okay, so deceased donor, you have the time to watch biology because the person sits on the list, and if they have a bad biology cancer, they're probably going to drop out. But with living donor, they're getting transplanted more quickly. So you can see that the 5-year outcomes for living donation are not as good because they get transplanted more quickly. So the 5-year outcomes are 61, 62% versus about 77% for deceased donor. So let's look at some of the studies that have been done. Well, as I said, you can see that in this study where there's 375 patients, this was an intent to treat study looking at deceased donor versus living donor. You can see that intent to treat, overall survival, intent to treat living donor, because they get transplanted more quickly, they have intent to treat better survival, but you can see that their recurrence-free survival is worse. Their post-transplant overall survival is worse because their recurrence-free survival is worse. And again, you can see in another intent to treat survival, there's lower dropout because the living donors get transplanted more quickly. So there's less chance that they're going to die on the waiting list because they're getting transplanted more quickly. They have shorter waiting times. And if you look, you can see that those that are within Milan criteria who have a living donor are actually going to do the very best. okay, compared to those who are outside the Milan criteria. Living donor for HCCs outside the Milan criteria. This is a study of, this hasn't been published yet. There is a group called NALDAC. It's a group of centers doing living donor liver transplantation in the United States and Canada. It's 11 centers. A lot of them participated in A2ALL, which was a big consortium. And what you're looking at here is a total of 411 patients who all underwent living donor liver transplantation. And you can see that these tumors are outside the Milan criteria, so more extensive tumors. You can see overall survival outside the Milan criteria, whether you were within or outside Milan criteria, overall survival is the same. But outside Milan criteria, if you look at recurrence-free survival, those people do worse. And if you look at the green line, that is the folks who are outside the UCSF criteria. That's an extension of the Milan criteria, but it's well accepted in the United States. It accepts bigger tumors instead of 5 centimeters, 8 centimeters. And the Milan criteria is the blue line. So what we're seeing here is that outside Milan criteria, you certainly have worse recurrence-free survival, but not necessarily worse overall survival. One interesting thing that we see is that if you're outside Milan criteria and you have a small graft, so we consider less than 0.8% graft weight to body weight ratio. So let's say a 70-kilogram man, a 1% graft would be 700 grams, okay, just to make the math easy. So a small graft is considered less than 0.8%. If you give a person a small graft and they have a tumor that's less, and they have a tumor that's outside the Milan criteria, they seem to have a higher likelihood of recurrence. Now, whether or not that's related to something to do with the regeneration that occurs and something happens with the fact that that tumor has a higher likelihood in the first place of recurrence, it's not clear. But that's really the first paper from, and this was from Korea, showing that the size of the graft that you put in may have an influence if you're putting it into a person who had a larger tumor. So there's more to be done there. You saw the data in the last day or two about cholangiocarcinomas being a great treatment. This is the Mayo data. They've shown plenty of subsequent data showing that their protocol is outstanding for perihilar cholangiocarcinoma, using deceased donor grafts as an excellent way of getting superb outcomes and curing people with perihilar cholangios. This is their data using living donor grafts. So out of the 247 living donor transplants they've done, 74 of them were in patients who had a cholangiocarcinoma. And this is really very interesting data. And I've had the chance to speak to both Julie Heimbach and Chuck Rosen about this data. So they've looked at, they pulled their cholangios who got living donors out of the total number of 247 cholangios. And the really interesting thing that you see here is that the patients with cholangiocarcinoma had a lower MELD. They generally had primary sclerosing cholangitis as an underlying liver disease as well. The people who were getting a living donor transplant for some other reason had a higher MELD, which isn't surprising, 18. The ones with cholangiocarcinoma had a higher CA19-9, again, not surprising. The ones who, they were about 11 weeks out from their radiation when they went to living donor transplant, the ones with the perihilar cholangios. Almost all of the living donors that they did got right lobe grafts. They all had good sized grafts, about a 1% graft weight to body weight ratio. The interesting thing was that because of having the the Mayo protocol, where they're doing the neoadjuvant chemo and radiation. The perihilar cholangios who went on to have the living donors, 90% of them required an interposition graft for their portal vein, and 10% of them needed a jump graft, an aortic jump graft for the arterial reconstruction. And that's a big deal when you're dealing with a living donor graft, because you get absolutely no risk adjustment with the SRTR, which is a whole nother kettle of fish, which I'll talk about later. But that is a really big deal, because that's a whole nother level of technical expertise that you have to deal with in that operation. 100% of them had a choledochal jejunostomy. And you can see overall, the hepatic arterial complication rate was 20% in the living donors, which is higher than normal. So if you look at their results, they had a higher hepatic arterial complication rate, and it was late. It was greater than 2 weeks. You can see that the hazard ratio is 4.17. The portal vein stenosis is higher than they would normally see in living donors. The hazard ratio of needing an interposition graft is 13. Biliary complications 1 month later, you can see is higher. And the presence of residual tumor was a huge indicator of whether or not there was going to be recurrence of tumor in that patient. The group to do the best, the blue line at the top, are the patients who had perihilar cholangios with no residual tumor. The ones at the bottom are the de novos. So the ones you didn't think had any cholangiocarcinoma, you found it in the explant, who ended up having residual tumor. And the ones who had primary sclerosing cholangitis with perihilar cholangios actually do better than the de novos as well. So they asked a number of important questions. You know, can advances in neoadjuvant therapy decrease the incidence of recurrence? Well, I mean, that's a good question, but I think the question is, will that also increase your complication rate in the operating room, because you might have more issues with fibrosis and issues with your vascular complication rate? Can advances in tumor biology help you select better? I think it's important. Would a longer window, you know, waiting after the radiation help you? It might make your vascular complications worse. You know, I think these are all important questions. You've also seen data, as I said, from the Houston group about the intrahepatic cholangios. This is with deceased donor grafts, and you can see the outcomes there. There's really not much at all using living donor grafts. This is from Germany. You've only got 6 patients. You've got outcomes of 50% recurrence and 70% overall survival. So I don't know that this is necessarily ready for prime time with living donor grafts. As far as colorectal nets, this is the Oslo group, and I'm sure you've seen this data. This is with deceased donor grafts. Again, seems very encouraging if they're well selected. Roberto Hernandez published the 10 patients that have had living donor grafts in this country. And again, I think this is very encouraging. But what's the problem here? The problem here is that transplant outcomes have become so good that we are so highly regulated that we can no longer innovate. That's the problem. We should be able to offer this to more patients. But now you have to sit here as a program director and say, I don't know if I can do this. I don't know if I can afford to do a living donor, because if that graft fails, I don't have enough N to be able to support a graft failure, because then my program's in trouble. And then the insurers will tell me I'm a program not in good standing. And now I can't get the coverage to do any more living donor transplants. This is why we need to work together as a group. We need your voice. We need a voice bigger than just the transplanters to stand up to the regulators and say, let us be able to innovate. We should be able to do this. We should have some wild cards where we can say, we know this is risky, but we want to be able to try this. So as one of my mentors, Blake Cady, said, biology is king, selection of cases is queen. The technical details of the surgical procedures are the princes and princesses of the realm who frequently try to overthrow the powerful forces of the king and the queen, usually to no long-term avail, although with some apparent victories. Ethically, living donor does have a role in highly selected cases of unresectable colorectal metastases and other, I think, advanced cancers. But we have to be able to innovate, and we are hamstrung right now with regulators. So what are the ethical limits of using a living donor? Well, the reality is you're taking a healthy person to the operating room and you're subjecting them to an operation that could kill them. And that's a big deal. If you Google it right now, a right lobe has a mortality rate or a possibility of having that person require a transplant 1 in every 500. The data is almost 20 years old. It's actually 8 deaths or transplants in 8,700, but this is what you will get if you Google. So this is what I tell potential donors. It's a concept of double equipoise. We constantly have to balance what are the risks to the donors, what is the likelihood of successful outcome in the recipient, what is excessive. We all know what's ridiculously excessive risk in a donor. We also know what is excessively, absurdly low outcome in a recipient. The question is the gray area. Now, Angie Wall had a beautiful talk yesterday. She showed a much more sophisticated graph. I'm not as smart as her, so I have a box. So this is actually developed by Mark Sigler at the University of Chicago. But what it shows you here is that the ethically acceptable, okay, is when the risk for the donor is extremely low and the outcome for the recipient is extremely high. So what is that? That might be a mom donating to her baby, a left lateral segment, very low risk, outcome for the baby, very high, okay? Anybody, I think, would agree that's a reasonably ethical and reasonable thing to do. Unethical, okay? Very, very risky for the donor, very likely bad outcome for the recipient. The gray zone is where we usually are sitting. So how does this work? You got a 45-year-old mother of 3, stable colorectal nets after 4 years of chemo, previous liver resection. Her potential donor is her husband, who's 50. He'll do anything to save his wife. He understands what's going on. He is probably going to be a right lobe donor. He's of average risk. So I would say that that pushes him from the, they've got 3 kids. You could potentially leave these kids orphans. So, you're kind of in the gray zone, but I would say he understands the risks. It's a reasonable average risk, pushes it to the ethically acceptable. 75-year-old man, unresectable colorectal mets, hypertension, type 2 diabetes, primary cancer was resected, developed mets 2 years later after resection, responds, has a 25% reduction in the size of his tumor. His loving 20-year-old granddaughter wants to be his donor. She's going to need to be a right lobe donor. A lot of people would say, fine, go ahead and do it. I look at that and say, she's 20, he's 75, he's got comorbidities, she needs to be a right lobe donor. I don't think it's reasonable. Other people might. But this is how you can use it. So to end, each case needs to be examined using the concept of double equipoise. There's no black and white answers. The decisions should be rational and based on data and evidence. You need to avoid being paternalistic and deciding for the patient what you think is the right thing to do. You need to acknowledge donor autonomy, but you don't have to be forced to do that operation if you don't think it's reasonable. And I think we need to consider the risk to the donor and the ability or the lack thereof to appropriately inform the donor of the recipient outcome. It's a slippery slope. Thank you.
That was outstanding, Dr. Pomfret. Thank you so much. We probably have, even though I know we're over time.
Oh, we
but
are over
we
time?
can have, we can have questions.
I just have what may be a political question, as I don't think you'll ever take away the ethical conundrum of what you just beautifully described. And I think the role of transplant and oncology is just going to rise, and we're going to find where that needs to be. What are we doing? And I guess when I say we, the transplanters, to help political situations where deceased donors can be increased, maybe opt-out systems? There must be politics behind this. And it seems to me that we can hopefully put living donors away if we can get more deceased donors. I don't know a lot about this, but I'm curious your thoughts about this.
Well, it's very interesting because, we've been expanding with using donation after cardiac death, where, people are donating in that realm. We've used machine perfusion to try to make not so great organs better. We've moved into normothermic regional perfusion, which is essentially putting the thoracoabdominal organs on ECMO. And right now there is a huge upsurge that has happened where we've got a lot of ethicists coming forward who are worried that normothermic regional perfusion could reanimate the brain. It can reanimate the brain. And there is a big set of conferences. Of course, they're happening on the same day because that's the US for you. There hasn't been anything for who knows how long, but we're going to have an NIH consensus conference, and we're going to have another thing all on the same day on March 21st, where a group of ethicists are coming together, and some people, not enough from transplant, because we all kind of found out about this a little late. And the problem is that this discussion about normothermic regional perfusion is built on the same premise as DCD. So I'm afraid that we could lose NRP and DCD and lose a huge portion of our deceased donor organs, in one fell swoop. I think we're one really skilled lawyer away from a big kibosh in transplant. I really do. And that's where I'm saying, I think we need to pull together. We've all been so busy doing our thing that we've sort of missed the boat on a lot of what's going on in government, in regulation, in all of these different things. I mean, the FDA is asking questions about pig organs. You need to guarantee that this organ is going to work. Well, you sort of don't get transplant. We can't guarantee that any organ's going to work when we take it out and put it into somebody, but this is what we're dealing with at this point now. And that's a real problem. So.
Thank you very much, Liz. That was amazing. I hope it was.